Good day, and welcome to Learning Thursdays. Learning Thursdays are offered to addiction professionals as a free learning opportunity and a goal of improving the knowledge, skills, and perhaps attitudes of the New York State substance use disordered workforce as we strive to improve the lives of individuals in prevention, treatment, and recovery services. The presentation we're going to have for the month of November is called Understanding the Military Culture and is being presented by Carolyn T. Jackson, Syracuse VA Medical Center, and Paul Noonan from OASAS Veterans Affairs. As a review, Learning Thursdays presentations are free of charge and routinely approved for 1.5 credentialing hours. After registration for each presentation, participants will be sent a link for the broadcast, typically the third Thursday of each month, that will include the PowerPoint handouts, a sign-in sheet, and a credentialing certificate. It's important that you remember to send the sign-in sheet to the address indicated on the form, as this is verification of your attendance at the presentation. What we'd ask you to do is type or write your name in the space provided and make sure you hang on to the original, as that's the only certificate you will receive. If you have any questions at any point about Learning Thursdays, feel free to contact us at learningthurs@oasas.ny.gov. So this is Patty, and I would like to introduce to you Paul Noonan from OASAS Veterans Affairs. Thank you. Welcome, Paul.
Thank you for your introduction, Patty. And hello, everyone. This is Paul Noonan, the OASAS Coordinator of Veterans Services. We're pleased to bring to you today a 90-minute presentation on understanding the military culture. This is something which OASAS, and I in particular, feel is very important for people who work in OASAS certified programs when dealing with men and women who have served in the military. Military has its own culture, its own way of speaking. It's really quite unique. And for those who have never served, it's difficult to understand, and that's the purpose of this presentation. I'm pleased to be able to introduce our speaker, who I've seen speak on this very topic a number of times and has done an excellent job, which is why we've invited her to join us today. Dr. Carolyn T. Jackson is a clinical psychologist with the Rome-based primary care team at the Rome community-based outpatient clinic as run by the VA. As I mentioned, Dr. Jackson has presented numerous times for us before at conferences we've sponsored and smaller training events, and is a veteran herself, and therefore can speak not only from the clinical end, but also from the personal experience end of military culture. So I'd like to welcome Dr. Jackson.
Thank you, Paul. I too share your interest in helping all of our community, individuals, families, military members alike, understanding about the uniqueness of the military culture itself. I'm pleased to be here today to provide this opportunity. We should start perhaps by highlighting that indeed very few people are active duty personnel overall in the United States. Indeed, less than 1% of the total population is serving currently. This is less than what we note during the World War II era, when that percentage was perhaps closer to 9%. We should also mention that currently nearly 15% of those serving are women. In terms of our most recent conflicts, we note that all branches deployed, of course, all branches of the service, to either Iraq, Afghanistan, catchment areas in those theaters, or both. And those numbers are over 2 million troops across all branches. And then of those troops, of those airmen, sailors, soldiers, and Marines, nearly half deployed more than once. So getting right into the topic of culture, we should first talk about training our troops, who are elite, the elite. The literature, the clinical literature, and the psychosocial literature, and the research literature is really replete with definitions of what constitutes culture. Although perhaps one of the most agreed upon definitions is the shared language, values, beliefs, and practices of a given group. So the military in and of itself is certainly a culture. During basic training, also known as boot camp, is when individuals are indoctrinated into the culture. And this is something, of course, as you know, that must happen, I'm assuming you know, and we can talk a little bit about that, must happen with a sense of urgency. Basic training length of time, weeks or over months, varies across branch, but certainly it's well within a year, well within several months for any of the branches. So that's a very brief period of time for individuals to understand the culture in and of itself, and to be able to embrace some of the language, values, beliefs, and practices to survive within that culture. One of the key core pieces of the culture that folks are able to focus on, probably perhaps the key component, focus on developing, is a sense of esprit de corps, spirit of the body. Individuals acting as a unit, behaving as a unit, which comes with a great degree of sacrifice. We should also point out that there are individuals who wash out. There is an attrition rate. It's quite low. We also sometimes term this washout, a washout rate. It's about 12% across branches, and the time that an individual military member or person training to become a military member is most likely to wash out is indeed within the first 6 months. We also believe, and there's some good literature, and we can talk about some of the citations from the Department of Defense, the Rand Corporation, the Pew Trust, where we can find some expansive information on these numbers. What we do know is that most individuals who are washing out or having an attrition, who are making up that attrition rate, are those who perhaps are leaving for medical and or mental health problems, including those who failed to admit that premorbid medical or mental health problem before enlistment. So still a low washout rate for individuals who do enlist. So that's the first component of training across all branches, basic training. The second component, which all individual troops, and I will often use the term troops to capture all 4 branches, and as I mentioned, the Army often termed soldiers, Army individuals termed soldiers, Airmen, Air Force, Marine Corps, Marines, sailors. We have the Coast Guard, of course. We never want to forget about the Coast Guard. These troops across all these branches, everyone will go through, experience some sort of advanced training, which also varies in length of time. I happen to be security police in the Air Force. In the early 90s, my advanced training was about 6 weeks. I was in basic training with a woman who was to become an interpreter, an Arabic interpreter, and her advanced training was 2 years. So it certainly varies, again, within branch and across branches and across what the specific role will be that the person is learning to realize. There's a great deal of pride associated with each position. We can talk more about that as we go through the slides.
Right, Carolyn. I just wanted to interject, as we're looking at this slide, that in my opinion, these values, the culture and the values that support it are probably more ingrained in troops than ever before, because you have to remember that these folks have voluntarily signed up. There has not been a draft in effect in a few decades. So these are people who joined up because they wanted to. So the esprit de corps, I would imagine, is a little higher in an all-volunteer force as opposed to one that's drafted.
I too can imagine that being the case, and we will talk about other cultural values that are implicit to the culture itself in addition to esprit de corps. I might agree with that. Of course, I only have my individual experience, and I was obviously post-draft. I would say also that for all training, another important component that's somewhat related is that regardless of the era and regardless of the branch, the training into this piece, at this point of being trained into this component of the culture, one must learn that all lives depend, each other's lives depend on peak and error-free performance. So there are extreme directives that these individuals are subjected to, and extreme conditions, extreme work environments, extreme hours, and as we're going to talk about on some subsequent slides, some extreme physical demands that are asked of individuals. So here we are with some of those cultural core values that we just alluded to. Duty, honor, country is one way of summarizing what the cultural core values are about for the military. And then if we break them down, really all branches would agree that, and in the Air Force we say integrity first. So these are in no particular order, but being an Air Force troop, I put integrity first. But for all, integrity, code, and there's a good bit of code to follow, respect, regardless, and as we'll talk about perhaps later, we discussed how an individual in the military will respect the rank, not the man or the woman, so to speak. It's not required that you respect the individual. You will respect the rank and the position. There's esprit de corps again. And flexibility, as you might imagine, is very important. These are deceivingly simple. Obviously, they're pro-social values, but if we think for ourselves, whether you yourself are a veteran, having served in the military, or a civilian, so to speak, these may not be as easy to realize and to live out in our lives as we read them on the screen to perhaps be. And again, these are pro-social, and so certainly for those of you who are meeting with people who happen to be veterans in a clinical setting, or where you're seeing an individual who has a mental health, behavioral health problem or a medical problem, sometimes there can be a confound where we can view the individual only in light of his or her illness, so to speak, or injury. And what I'll encourage you to remember here on this slide is that these individuals survived something. Having been in the military, these individuals certainly at some point were trained in, and as Paul, you were saying before, subscribed to some pro-social adaptive values, adaptive way of being. And I work with an individual who happens to be a retired E9 Marine, and he said, well, don't forget the most important value. And I realized I don't have it on the slide. I said, what is that, Top? And he said, loyalty, of course. If we are not loyal, then we will not be realizing any of these other core values.
And interestingly enough, the phrase, duty, honor, and country is the motto of West Point.
Ah.
Just thought I'd throw that in, Carolyn.
I like that. You are a history buff after all. So in terms of moving away from some of the overarching notions in terms of the cores of the culture, the core values, for instance, the core ways of being, the core experiences, we should also talk about some of the risk factors and consequences, if we can use that term, of membership in the military culture itself. So, as many of you know, the onset of many behavioral health conditions, mental health conditions, for everyone, for all of us, advanced primates, is late teens, early 20s. Well, think about how late teens and early 20s is often the age of enlistment in the military for a number of folks, perhaps most of our, I don't know that percentage, but I believe I have read certainly most individuals are enlisting probably prior to the age 25. So if we think about late teens, early 20s often being the age of enlistment and onset of mental health conditions being late teens, early 20s, that's a recipe for disaster potentially. One model, as many of you also know, of understanding the development of mental illness, mental health problems, behavioral health conditions, is the diathesis stress model, which of course posits that the individual human being has perhaps a genetic predisposition to a particular condition, mental health condition. That's the diathesis, and then there is a stressor in the environment that will, the individual either be exposed to a stressor in the environment or not exposed to a stressor in the environment. If he or she is exposed to a stressor in the environment, it will activate that diathesis, and we will see the manifestation of the mental health problem. Well, enlisting in the military, regardless, even under the best of circumstances, can be considered a stressor. So that could be perhaps how we're noticing these mental health conditions coming about at this point in time for our military individuals, specifically here today. Another component that we should also remember is that brain development is still forging for quite some time, and we know that the frontal lobes, which are responsible for executive function, planning, organizing, controlling impulses, inhibition, that component of the brain, if the individual has enlisted before the age of 25, may not be fully developed yet. So thinking about also how individuals can be in a war zone, in combat even, at the age of 18. I know for myself, I am not a combat veteran. I did enlist at the age of 17. I turned 18 in the Security Police Academy. So very young individuals, so we have that diathesis stress model where we know that we're going to see the onset of mental illness at that point, for many of our conditions anyway. And then we have a brain that's not necessarily, perhaps is not, fully developed to begin with. Another component related is that a number of individuals who enlist are hailing from backgrounds, communities, where they are coming from families, environments, neighborhoods, which may also already have a number of risk factors happening for them. So perhaps poorer communities, lower socioeconomic strata, perhaps prior exposure already, pre-morbid, pre-military exposure to trauma or exposure to substance abuse within their neighborhoods or homes. Something important again to consider, this slide in particular, could be a recipe for some individuals for the perfect storm, if you will. Even under the best of circumstances, again, regardless of the environment, the background the individual has hailed from upon enlistment, all will be separated from loved ones, family, and familiarity. Another stressor, yes, in terms of the diathesis stress model, and then repeatedly relocated and or deployed. As we talked about on our first slide, certainly for these most recent conflicts, many people are deploying more than one time. I personally have met an individual who has deployed 7 times. Some other individuals have mentioned numbers almost double that. They've met veterans who have gone again and again and again to combat. Repeated relocations and deployments, obviously, not only just the separation from the loved ones and familiarity, but continually and repeatedly being exposed to trauma or traumatizing, traumatic situations. Also, constant fight or flight. So if we know that there is a difference between fear and anxiety. Fear is when we're walking through the woods and we see the bear and we must act. Anxiety, as we're going to talk about later, is walking through the woods and believing and thinking, perhaps, worrying that the bear is around every tree. So being constantly on guard, perhaps without opportunity to act. So being in constant fight or flight, so to speak, is being on guard, not only for those physical threats in the environment, perhaps in a combat zone, but also the ever-present measurement against peers. There's a good deal of, as you might imagine, some of it good-natured competition, but also we will be measured against one another. And so if one individual falls out, the rest of the individuals will not be moving forward without him or her. So there is certainly an expectation and an ever-present pressure to maintain one's tandem with one's peers. As I mentioned briefly in the beginning, there are certainly protracted hours and unusual schedules, and I would summarize that set of bullets by stating it's really go, go, go to the extreme. And as we're going to talk about here shortly, that can mean go, go, go to the extreme in a number of areas, even ones that are not pro-social or healthy. As you might imagine, in summary, with these two slides we just discussed, individuals in the military, then we know, military and veterans later, are unlikely to report problems early on in the disease process voluntarily. We know this, which of course, whether it be medical or behavioral health concerns, can allow the condition to fester.
I just wanted to, so it's really almost a constant state of vigilance.
It is a constant state of vigilance, indeed. Yes. And then manifesting in the lasting clinical term hypervigilance, certainly among some of the anxiety disorders, yes. And it's designed that way, so to speak, within the culture. It's implicit to the culture. It was meant to be that way at one point, and perhaps adaptive, certainly in a combat zone or in certain situations. But for our purposes as clinicians and providers and family members and community members who hope to welcome people back from the war zone, it's important for us to help them come home for real and understand that that hypervigilance isn't adaptive or healthy or healthful for his or her quality of life now. And that relates to our next slide. There are two major, if we can break them down, clinical impacts of serving in the military. So we talked about risk factors and consequences. Here are the clinical aspects, clinical impacts. As we know, as we just started to discuss, there are mental health problems, whether they be emotional, cognitive, so in terms of thinking, ways of thinking, which gets to some of the brain injury piece that we're going to briefly touch on later, and behavioral injury. I encourage people to, on this slide I want to mention here, to maybe look around at some of the literature on moral injury. I think that's something we don't talk too much about yet, and I would maybe subsume that under behavioral injury. Certainly if someone has had to deploy to a war zone or into a combat situation, depending on, at this point, his background, premorbidly, prior to being deployed, these are not situations that many individuals morally, perhaps, would agree to, frankly, or would typically feel were moral actions to engage. And I stumble because it is a difficult topic. It's a very delicate topic. I encourage you to read some of that literature and perhaps talk with your patients, your clients, about that piece. So, but more innocuously, we can talk about a psychological trauma, obviously. There is that chronic exposure to mental stressors, so being moved around a good bit, as we talked about, being ever vigilant, as Paul was mentioning, reminding us, being separated from those original support systems. And I believe, so we talked about original support systems in terms of family and culture, community of origin, neighborhood of origin. Also think about once individuals have deployed, I believe now they deploy as units and they are yoked with their unit. I'm not sure that was the case maybe in, you may know this better than I, Paul, with you know a bit more about military history than I do, frankly. I believe that, for instance, with the Vietnam era troops, they could be one individual moving into another unit. So he in this case, was not necessarily moving with his original support system even after he'd gone into the military. Am I correct to remember it that way?
I believe that's true, Carolyn, in the case, especially around the time of Vietnam and during Vietnam. Platoons were not leaving basic training intact. They were being, various members were being assigned to different military occupational specialties. So that's true.
Yes.
Whereas I believe they try and keep the unit intact today, especially, well, when the National Guard, excuse me, deploys, they deploy as entire units.
Yes, which, given what we've just said, makes sense and probably is healthier for folks if they are having to deploy into those situations. And then back to the piece we discussed before about individuals perhaps delaying presenting for services, delaying acknowledging the illness or the injury till later in the disease process. We're going to talk a good bit about this later also. Stigma. There is stigma associated with seeking help. Now then, for all of us as human beings, certainly in our Western society, acknowledging a mental health problem, there's stigma associated for all of us, unfortunately, even still. But perhaps above and beyond, or even more so, for individuals who happen to be military members or veterans, to be tough and to have grit and to be part of the elite. And we're going to talk about that notion of stoicism here later. So the first is mental health problems in terms of the two major clinical impacts. And then, of course, we must mention the medical health problems. The psychological trauma and experience may be underlying, but on the surface, and perhaps beneath the surface, there are blast injuries, blunt force trauma injuries, terrible burns, penetrating injuries, and then amputation injury. The person has lost the actual extremity or any component of his or her body. So there is that physiological trauma, chronic exposure to physical strain. Even if people are not deploying, even if people are not coming into combat zones. I know for myself, at one point I worked as a gate guard for a number of years, and standing on a gate waving traffic sounds pretty simple. I know I'm Air Force, military light. However, standing on concrete for 15 hours straight at a time, the body was not designed or has not evolved, whichever you prefer, to withstand that. It's not natural, that's not healthy. And then folks carrying heavy packs, jumping out of areas, high areas, crunching down into spaces where they maybe shouldn't be. This is all chronic exposure, repeated exposure to physical strain, and we're going to talk about some of the manifestations of that, what that becomes later. And then when individuals are downrange, if you will, out in the field, there is a separation from immediate health care. So even if he or she were to present or to wish to engage that health care, it may not be available immediately as the person's in the field. And then just like with the mental health problems, with the medical health problems, there is stigma associated with admitting to the wound itself. There's a lot that goes into that. If the person is injured, he or she may be separated from the unit, as we talked about before, left behind, if you will, not left behind in the field, of course, but left behind in a medical setting if we are able to get them to that type of care. And so individuals, again, might be less likely to admit to even medical wounds, physical wounds and injuries.
It reminds me of many of the old World War II propaganda movies I saw as a kid, and I don't know how many times I heard the expression, "It's just a scratch," when it really wasn't.
When it really wasn't. That's right. That's right. So as we alluded to a couple of moments ago, if we can we talked a bit about values, and now we're going to talk a bit about cultural expectations. And we would argue that the reigning cultural expectation is this notion of stoicism, which by definition definition rather, is an emotional indifference or at least the expectation of appearing unaffected, appearing as though it is just a scratch, whether that be physically or emotionally. And Stoicism, also known as significant patience and endurance shown in the face of adversity. So some of the terms, and we're going to talk a bit more about mil-speak, some of the terms or phrases that may be used to further this notion of Stoicism among the troops, by the superiors. I heard this a lot. We heard this a lot. Suck it up and press on. Oh, you're hurt? Suck it up and press on. You don't like it? Tough. Suck it up and press on. Suck it up and press. We also hear, and there's a good bit of profanity, and the notion that stuff ain't hard. And stuff is hard. But being told again and again that stuff isn't hard perhaps implies to the individual that if you find it hard, maybe you're the one who's wrong. It's not that it really is hard, it's that you're not doing enough, you're not tough enough, you're not strong enough. Adapt and overcome, regardless of what one is facing. And my favorite, if the Army wanted you to have feelings, it would have issued some. We hear that about everything. You have what we wanted you to have because we issued it to you. And if you don't have it, it's because we don't want you to have it, and that's why we didn't issue it.
And this goes right back to that vigilance thing again, right?
It does. It does. And again, so what we're seeing here, what we're pointing out with that very notion is repeated indoctrination, ingrained over and over and over again for individuals. Necessarily, much of it. Although we're thinking on the other side, again, as family members, community members, clinicians, providers, welcoming folks home, there's some undoing, some relearning that needs to happen for people to live their best quality of life.
Now, I just have a question. Is this more, I would imagine this is more prominent in military personnel who've experienced combat than it is in those who have not? Or is this something that's present in all members?
I will answer for myself, and we'd have to look and get a nice survey of folks. I'll speak for myself. This is something that I heard quite a bit, and again, I was in some very peaceful years, if you will, in our military. I never deployed. I deployed overseas several times into various locales. I was never in combat or in a combat area. We heard this all the time from basic training forth. We even said it to each other. You know, suck it up, gimp. You're not injured, it's just a scratch.
Oh, yeah, I believe it.
Right?
I certainly believe it.
Yeah. We're going to talk a bit more about language because I do think that's a really important point, Paul. I mean, language is the transmitter of the culture. So if we can understand the language, maybe we're not using it if we're not military members in that environment, but understanding the language and its origins and where it's coming from and how it's utilized can help us understand the culture better.
So I would deduce from this, and I would hope that people are aware of this as they listen, that it's not necessarily a hard life in the military, but it is a demanding and sometimes burdensome life, whether you've been at war or to war or not.
My brother, who was in the Marine Corps, had said before, it's not that it's hard, it's just that it's so damn daily, which applies to more than the military, I'm sure, but I think that's right. It's always, 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 that's right. In terms of those clinical responses to the trauma that we've discussed on some slides previously, it's important to note that almost half of our individuals will return with medical and/or behavioral health symptoms, not necessarily meeting full criteria for a behavioral health condition, for instance, but certainly presenting with symptoms. The most often reported complaint is the chronic physical pain. Indeed, it's the chief medical complaint reported, and that's about 50% of individuals will return with chronic physical pain complaints. And that again harkens back to what we discussed a few slides ago about carrying heavy packs, perhaps scrunching down into places that are not meant to be utilized for that, jumping out of areas, injuries. So injury related, that chronic physical stress and strain and perhaps injury.
Well, it's very physical work, without question.
It is very physical work.
And I've been told that today's technology has enabled many an individual, many a soldier and Marine, airman, sailor, to survive wounds that would have taken the individual's life in earlier conflicts. So many of them are coming home on top of the normal aches and pains from their physical labors. Many of them are coming home with chronic pain from wounds.
Indeed. Indeed, and what's important, one of the pieces that's important for us to remember with that is that given that the chief medical complaint is going to be, and the chief complaint overall is going to be that chronic physical pain. You remember we talked about how many individuals are going to, perhaps most, are first going to present to a medical provider before they present to a behavioral health person. So what's important with that is for us we as behavioral health individuals and providers to collaborate with our medical staff and to help them understand how to screen, even some quick screens for mental health problems while we have them in the office there for that medical complaint. Post-traumatic stress disorder is one of the hallmark injuries, we've termed it, certainly for injury or illness. For our returning troops, about 25% are coming back, meeting diagnostic criteria. Now, that doesn't necessarily also, by the way, doesn't necessarily mean coming back from combat. We have individuals coming out of the military who did not serve in combat who are meeting full diagnostic criteria for post-traumatic stress disorder. What's interesting about this number, something perhaps we don't think about, is that what this connotes is that most people do not come out of the military with post-traumatic stress disorder, which is good. And it's also good that we're talking about these conditions.
That's a very good point. So it's important to note that service does not guarantee you will have PTSD, which sometimes the media almost really confirms that almost. Agreed.
Certainly implies that. And then secondly, and you mentioned this certainly with the medical injuries, but also with our technology advancing all the time, with traumatic brain injury, individuals may be surviving certainly blunt force blast trauma better than they did before, more likely to survive that. So we are noting the second hallmark condition coming out of the service now is this TBI, traumatic brain injury, up to 23%. And then major depressive disorder, nearly 15%. Again, some of these may be dark numbers, if you will. Individuals, as we talked about, again, also a few slides ago, may be less likely to report conditions until later in the disease process. And many of these conditions, as you also know, are comorbid, co-occurring, dual diagnoses. Certainly when it comes to substance use disorders. Right now we believe perhaps over 10%. We've put a question mark there because if ever there was a dark percentage, this is probably it. Individuals may not be as likely to acknowledge substance use, substance abuse. Also importantly, something that many may not realize is that compared to the general population, the military and veterans are less likely to abuse illicit, illegal substances, less likely than the general population. However, they are more likely than the general population to use tobacco. Smoking to stay awake, chewing tobacco to pass the time, perhaps. I mean, we can talk about, perhaps later, some of the components of why that is. Also, unfortunately, more likely to be abusing prescription drugs than the general population. And then far more likely than the general population to be using and abusing alcohol. In fact, there's some more recent research, more recent data coming out that our military troops are binge drinking more than our college populations. They've now surpassed the college folks. Yeah. Yeah, it's so this is a warrior culture. Being a warrior is core to the culture, and warriors are bred to tolerate those extremes we talked about on that first or second slide. So perhaps the culture, this is my sense, perhaps implicitly endorses and encourages excess and tolerance of everything, maybe even including alcohol.
Well, I do know that it's until recent times, it's been alcohol has been almost a military tradition. I've been told the Marine Corps was founded in a tavern, for example, and I believe that's true. And I think sometime in the early 70s, up until sometime in the early 70s, the Navy was still issuing a daily ration of grog, which was primarily rum, to any sailor who wanted it. So this is what we're dealing with.
Right, and we've talked before about, this is anecdotal from some of my clients, patients, the Vietnam era gentlemen talked about pallets of beer being brought into the zone for them, being brought in theater. Alcohol was a bargaining chip often to get what they needed with one another. Cigarettes in the rations, cigarettes in the meals ready to eat. So yeah, certainly a piece that was implicit to the culture, maybe, and we're going to talk here momentarily, perhaps even encouraged, not only endorsed, but encouraged. I do want to say a brief word very carefully about opioid pain relievers. There is a benefit, obviously, given that we talked about that chronic, sometimes intractable pain. Sometimes that is what the medical provider, which I am not, the medical provider may need to prescribe to help the individual, certainly through a period of time. So there is a benefit to the opioid pain medications that are prescribed for some of our military troops and veterans. They do assist in intractable pain management. However, there are also drawbacks. So not only in our system, perhaps government systems, but also community systems, perhaps across the systems, these types of medications are susceptible to multiple prescriptions. I notice there's not a citation on the slide, and I can certainly provide viewers the citation for this if you are in touch with me at some point. There are estimates more recently that there are enough pain medications prescribed right now where every single active duty military member could have 1.5 prescriptions per person. That's the number of opioid pain relievers that are being prescribed to date. And that's a pretty recent statistic in the last few years. Unfortunately, so it may be helping with the intractable pain, but it also allows for this increased emotional withdrawal and isolation. And for those of us who are behavioral health providers, especially when hoping to assist with post-traumatic stress disorder, one of the symptoms, one of the behaviors involved is experiential avoidance. I've worked in groups at the Cleveland VA where gentlemen would talk about drinking to the point of passing out so he could avoid a nightmare. So this could also be happening with the heavy-duty opioid pain medications, perhaps allowing for a person to check out, perhaps using it for anxiety. When we have anxiolytics that can be utilized for anxiety, it's really not what it's intended for, and maybe is being used for that use when that's not its purpose. And then naturally, there's a risk for secondary dependence.
Have you noticed any one or more specific opioids that are more popular than others?
I'm not sure I want to speak to that. I really can't answer that. I would say the opioids as a group of drugs and medications, we should keep our eyes peeled for that. I will say that we have, in VA in particular, we are helping, and we're going to talk about some of the treatments later perhaps, but some of the medically assisted treatments for substance abuse conditions. There are some medications such as methadone, Suboxone, which are being prescribed and being allowed to help individuals wean from some of the other opioids. I was hoping we could spend some time on the fact that the military has a drinking problem, and I will say it. The military has a drinking problem. The heavy and binge drinking is clearly endemic to the culture, has become more recently. I separated in the end of 1999, 2000. Even then, we had beer refrigerators, we worked and drank. That was what we did. Alcohol is available and cheap, as you mentioned before, Paul. It's certainly related to the camaraderie. So celebrations have lots of alcoholic beverages available, promotions, dining-ins and dining out, these more formal gatherings. And there's acceptance around appearing intoxicated, if not on duty. And if not acceptance, perhaps there's a structural hierarchy where no one wants to get in trouble and no one wants to get fellow troops in trouble or subordinates in trouble. So there's perhaps a silence that happens if we do notice that someone may have a problem. That may be not only the individual less likely to report that, but those around him or her as well.
Well, certainly, yeah, because your subordinate's behavior reflects directly on you as an officer or NCO.
For sure. For sure, and there could be a good deal of normalization when we're in this culture, when individuals are in the culture, sort of a vacuum effect, even if we're stateside, even if we're not in a combat zone. On bases and posts and camps, there are mostly military people around, and it may not be as noticeable. I mean, I'll speak for myself. I didn't think of it until I separated years later, how much we drank, how much alcohol people were consuming, how often some people appeared intoxicated when off duty. Yeah. And nobody wants anyone to get in trouble. So some of the symptoms that, as I alluded to before, that alcohol might be utilized to manage physical pain, that chief complaint, emotional pain, stress, a stress reducer, sleeplessness. Of course, we know that alcohol interferes with sleep, certainly attaining the deepest and most restful stages of sleep. But as I mentioned before, perhaps an individual believing that he or she can pass out and avoid any sort of nightmare activity, boredom, and loneliness. Just briefly, there are some challenges to transitioning from the military zone to the home zone, and I believe perhaps most viewers are working with people who have come back to the home zone. In the military zone, there is a sense of cohesion. In the home zone, that may be more isolation. Certainly coming home, maybe not being around your unit anymore, but maybe not even being around other individuals who have served in combat or otherwise. Whereas it was accountability in the military zone, there's lack of control here, perhaps, in the home zone. Tactical awareness there, and we talked about this before. Tactical awareness is adaptive in the military zone, in the combat zone, in the war zone. There are lots of terms for this, and they're used interchangeably. In the home zone, it becomes hypervigilance. It can be a clinical problem. It's not adaptive anymore. Emotional control in the military zone can become detachment, which relates to that first bullet of isolation. Discipline in the military zone can feel like a disorganization. Again, for myself, I enlisted when I was 17. I was young. And so to have left the military where there was no more external discipline was a transition for me. What the heck do I do now? I remember taking my first college class a few months after I'd gotten out, and there were people sitting in class in their pajama bottoms. I remember finding that shocking. I couldn't believe that you could do that. So something as simple as that. Obeying orders in the home zone may become giving orders when an individual, again, if he or she is a lower ranking person, certainly, or having not had a command, even of a fire team, can be a transition challenge. And in the military zone, where some behaviors may be normal, they could be stigmatized behaviors here in the home zone, or behaviors that appear odd and ill to others. And you'll remember when we had a conference recently, you and I, we attended in New York City, and there was an attendee who mentioned, she said, we do a very good job at compressing civilians into troops, and we do very little to decompress troops back into civilians. And I thought that was a brilliant way of putting that. You know, there's a great deal that goes into, as we talked about very early on, this training, this indoctrination, but then folks are just released and here you go. We're getting better about that, as I understand it. I know there are more transition programs, a bit longer. There's been some suggestions that the entire family could go to what's one senator called a deboot camp, sort of a retreat for the entire family to do. And I think maybe talking about some of those things is probably going to be helpful, a place for us to take some of our clinical workings.
That's a common complaint I've heard often, how the military trains them to be members of the military, but doesn't train them to return to civilian life.
Right, right, right. So it's for all of us to do as a community. I think we're ready for the challenge. There are two main barriers to seeking help, and we've discussed some of these throughout. Inaccessibility. So some individuals may be unaware of the services that are even available to them. Again, I think we're doing much better about this with outreach among the, the federal government, the state level, and the community level. For where I am serving right now in Veterans Affairs, the health side of the house, it's tricky because folks must return to a paramilitary organization, which truly we are, for some of their treatments, and that can be dicey and complicated for some. This third bullet is really more about benefits, and you can contact your local veteran service officer. You can just Google who that is, wherever you may be today. They go by county. They can tell you about benefits for yourself or for your clients and patients, but there are gaps in TRICARE, and for our piece at VA, there are some gaps in what an individual is eligible for and when. And as we talked about in the beginning, we also know already that initially most who do seek care will do so in the community first. So with those medical providers and also with community providers like your organizations, Paul.
Right, and I just wanted to stress that, yeah, each county in the state does have a Veterans Affairs Bureau or department. And in New York City, of course, the mayor has an Office of Veterans Affairs as well.
There are two main barriers to seeking help, as I mentioned, and the second is that word again, that notion again, stigma. Cultural expectation to have grit. The individual may simply choose on his or her own not to not present. Lack of confidentiality, or at least there could be a concern about whether the individual will retain his or her confidentiality, having been in the service in that culture where everything really is on the table. Some are concerned about reprisal. Will this be reported to my commanding officer? Will I lose benefits? What will this mean? Especially when people are in the midst of transitioning out. Had some individuals, obviously some of the conditions may not onset right away as they're transitioning out of the military, but some clients have talked about, I knew I was sick, I knew I needed help, I really just wanted to come home. I really just wanted to get the heck out of there. So again, stigma, 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 and so stoicism. If you take nothing from this talk in terms of the culture, for our side of it as providers and clinicians, be looking into the literature around stigma and how that plays in the room as you're sitting with the individual person. Just briefly, I thought we would touch on some mil-speak, and it is a term, military language, for patients and providers. There's some they're pretty good. There are a few books out more recently. They're essentially military language dictionaries. You can look them up online. And on the left-hand column, these are some of the terms, and there are a number of them. Many of these are some that I heard when I was in. Some of these are probably updated at this point. On the left side, some terms for patients who are either injured or maybe admitting to an illness or injury or presenting for treatment, and they're pejorative. they're pejorative. I mean, to be called a gimp or a foot dragger for, as you said, you know, asking for a Band-Aid for that scratch. I mean, it really takes away from, and again, they're pejorative, negative terms. Doesn't do well to encourage anyone to present for treatment. And then on the right side, for us, although the top term there is actually, should be in the left column, the bird really is for a person who's, you know, not pulling his fair share, not pulling his or her weight, whether it be due to mental health concerns or not. But the last three bullets there on the right-hand column are terms for, the first one, the checker is a medical doctor. A wizard may be what we would call a mental health person, a mental health provider or clinician, or what we're providing being voodoo. I know, Paul, you and I were talking a couple of years ago. I had a patient a Marine, Vietnam type, combat Marine. When I first went to see him, said, well, what are you going to do, Voodoo Shrinky? What are you going to do for me? He was in a primary care. Again, I work in a primary care setting, so he was being seen for his medical concerns, and the nurse had the good insight to know maybe you should see the counselor as well, see the psychologist. And he was willing for the visit. But I walked in and explained, you know, gently about what we do, and he said, I don't need this mystical hoo-ha. This is mystical hoo-ha. Well, that individual, within that year, doing some acceptance and commitment therapy-based work, is now, not only does he engage mindfulness meditation, he's no longer having any depressive episodes, or hasn't in quite some time, with his major depressive disorder and his PTSD, and he is a member of a Buddhist meditation center where he goes every week. So, and I tell him, I reference him in the talks, and he loves it. But that's, so I say that to you for the viewers because you may be coming across some of that in your setting with the folks that you're working with, and I encourage you to gently and in a supportive manner work through that. That's not specific to you, that's not necessarily personal. Some of that is about the culture and working through that stoicism, working through that stigma.
So you're not going to be filling in any of the blanks here on this slide.
You can fill them in, Paul. They're implied. I typically do fill them in. I typically will in a talk say them because I think it's important. This is part of the vernacular of the culture that but I'm not sure about forever on tape.
Well, we did mention the word profanity. Right.
Yes. Yeah.
And I guess some of this would qualify as profanity. So.
And again, you can look these up. There's some really they're some pretty thorough books. They're brief but thorough dictionaries of Mill-speak. So I encourage you to check those out. I use a lot of Mill-speak myself still, not the profanity as much. We use a lot of brevity codes. We use them in VA as well. So it can be helpful if you are working with the person who is a veteran to maybe have some information about the language. And if you don't know, ask. It's okay. I would summarize it like this, certainly for the alcohol use and abuse. This really summarizes that perfect storm that we talked about before. A recipe for disaster. Dilute any combination of those risk factors and or consequences of a hurry up and wait culture with 3 shots constant pressure, 2 shots extreme conditions, and 1 shot adrenaline. Add a twist of intensity and a splash of boredom. Shake vigorously with plenty of loneliness, emotional discomfort, and physical pain, and then serve dirty or chase with a frozen mix of stoicism and stigma. I made that up, and I'll tell you, that occurred to me one night while I was putting this together, that this is what it is. If this was a cocktail of this military culture and then some of the substances, certainly the alcohol, this is what it would look like. Yeah.
You made that up?
I did.
Wow.
Yeah. Well, it makes sense. I mean, I'm not even surprised, actually. It just, when I look at it, I think that is exactly what it is. That's the recipe. And it is problematic. It is problematic. And then also goes with that, this grand dichotomy, if you will. And you talked about this at the beginning a bit, Paul, the act of engaging the behavior, certainly with the excess use of alcohol. The act of engaging the behavior is endorsed or even encouraged. And then perhaps seeking help to remedy the behavior and its consequences is punished or runs the risk of being punished.
And that alcohol really never goes away, because I know VFWs and American Legions are very, very popular places.
They are popular places, and they have become, some of them that I've been in, I obviously can't speak for all of them or the majority of them, but they've become bar rooms rather than,
Absolutely.
rather than only clubs, which is tricky. The mean age of my population is 76. I have mostly Korean War veterans at this point and Vietnam veterans, and often looking for places where they can go, be out, engaging their behavioral activation, engaging their being present in the moment and their experience. There aren't very many places to go and consort, if you will, with other veterans that don't have alcohol
Right.
involved. Yeah.
Right, and many of them in this state allow smoking.
Do they? Oh wow, I hadn't even realized that. And I should say there are organizations, and I'm sure some of you know about them. There are some organizations where people can go and have fellowship with other veterans that don't involve alcohol, although all the VFWs have alcohol, all the American Legions have alcohol, all the veterans of foreign wars posts have alcohol. I think that's what we're talking about here, and I didn't realize about the smoking. So, we're coming toward the end here. In terms of what do we do? In terms of breaking through some of those barriers, I think providing, and the literature would support, providing sort of a psychoeducational inoculation, if you will. So telling troops as they're enlisting, having maybe those pre-enlistment briefings about what to expect, that this is implicit to our culture. There is a lot of drinking that goes on. Here's some ways you can remain safe. Here are some ways you can ensure or help ensure, increase the likelihood that this doesn't become a problem. Maybe being more transparent about that to begin with, so we can reduce the onset of the tendency to use or abuse, not just alcohol. I continue to mention that because that is the premier substance of abuse here for this culture, but aiming to reduce the onset of use or abuse for any of the substances, and highlight and de-glamorize the use or abuse. Glamorize is probably a strong word. I don't know that it's glamorous, but certainly calling it out of the closet, calling it out from the shadows, and talking about how this goes on here, and it is implicit, and maybe it's not okay, and offering some alternative activities, alternative ways of individuals maybe having fellowship while they're still in and when they are separated or retired. Illuminate the problem as a problem where the individual is not the problem, it's the problem that's the problem, and purposefully fighting that stigma. Encouraging them to understand we have solutions, we have treatments. Normalized throughout, and so bringing up that, certainly as we're screening, bringing up that this is a problem, certainly for veterans or people who are still in the military, and so focus on and encourage and reward those adaptive core values that we talked about before, because many of these individuals have them. When I talk about normalize, I don't ask, do you drink? I ask, how much are you drinking right now? How much have you had to drink today? You're nodding yes. I mean, this is something that we know as screeners. Using that language, that more language that's easier for the individual to answer. Providing alternative activities, as we talked about, promoting health-enhancing behaviors that have nothing to do with alcohol or substances, an endeavor to transform the culture, which we're doing a bit of today here by talking about it, looking right at it and talking about it, I think, as military members ourselves, or veterans. Offering wraparound care, we need to strengthen our substance use disorder workforce, so recruiting specialty and culturally competent counselors. We didn't talk about the demographics of who are enlisting in the military. There are certainly various races, ethnicities, obviously genders, ages, folks coming from various backgrounds. So culturally competent, or at least culturally sensitive, is probably a better term. Assign pharmacists to help monitor the medication piece. Believe it or not, we don't always have that. Medical doctors are very good, and pharmacists are also very good. And so assigning them in tandem can be helpful to help monitor the medications and ensure there isn't polypharmacy, so to speak. assess and treat the co-occurring conditions. As we talked about, there are a number of dual diagnoses, applying only the empirically based practices, empirically supported treatments, and ensuring that you're accessing and integrating a range of treatments. I have the opportunity, as I mentioned, to be working in a home-based primary care team, so we are interdisciplinary. We have a physical therapist, we have an occupational therapist, a social worker, a dietitian. But it can also mean integrating a range of treatments within discipline, so offering various, maybe offering some cognitive behavioral therapy and also some family therapy, the medically assisted treatments, etc. Advertising and providing private self-screens, I think, is really important. These can be done online, where individuals in the privacy of their own home can at least screen, answer a few questions, and determine whether his or her use or abuse of the substance is a problem or approaching a problem. So that comes also back to the psychoeducational piece and knowing the area supports and treatment entities. You can Google or you can look up online. The SAMHSA website has a treatment locator. In fact, you could just Google those terms, I believe, SAMHSA treatment locator for SUD, and it shows you everyone's information is there. Clicking on your state and in your area, and it will bring up whether it be federal, state, local community. So there are a number of area supports and treatment entities, and we should know what they are, certainly for our individual area, to offer to the patient or the client. Provide that safe respite from authority, so it's okay to come right out and say, and in fact I encourage it, that no one knows what happens in those confidentiality statements. No one knows what happens here. You have confidentiality, and that includes your family, of course, but that also includes, back to that military piece, that includes your commanding officers or anyone you worked with in the military, etc. Providing resources for the family, obviously. They are in the frying pan too, as I often talk with family members about. And this is more of a benefits piece, Paul, this last bullet, assisting with upgrading access to earned care. So it's called correcting the record. There are ways of going about helping an individual at least get in contact with that information or get in contact with those benefits officers that we were talking about before. When I say upgrading access to earned care, that can sometimes mean looking into or at least attempting to upgrade a discharge. And that can be done. And there are forms and processes, as you might imagine, to go through to do that. And I at least am aware, try to be aware for wherever I'm working, whatever county I'm working in, who the best individual is to connect that person with, and if they are able to be online, understanding where those documents can be accessed. And obviously addressing homelessness throughout. I think it's important for us to finish with our second to last slide here, back to what we talked about in the beginning, and that is remembering, we talked about some clinical information here today. We talked about some of the downside of individuals having served. Understand, we are welcoming them home. And I don't say thank you for your service. It's not as if I'm not grateful. I am. I say, regardless of the era, and I work with veterans from Iraq and Afghanistan as well in the past, welcome home. And I still say it to my veterans who are from Vietnam era, welcome home. And I remind them, it can take a long time to come home. That means a lot of different things to different folks, but welcome home. And as we welcome them home, do remember the pro-social piece. They are trained leaders, just implicitly based on their inclusion in the culture. They are team-focused, self-confident, dutiful, obviously organized and disciplined and staunch in their work ethic. They are dedicated to mission fulfillment. Remember, most who enlist do stay. Owners of cross-functioning skill sets, that's for sure. They are problem solvers, and they must make swift and creative decisions and solutions, and they do. They're able to adapt flexibly. They will keep the procedure steadfast in a steadfast manner, and really are champions and warriors. So this is from some of our suicide prevention literature at VA. I really like it. I refer to it often, even if it's perhaps a geriatric, a veteran happens to be geriatric, encouraging him to allow his home health aide to help him bathe. It really does take the courage and strength of a warrior to ask for help. So that can mean at the very beginning, very early on, and much later as well. And so thinking about who we have the opportunity to serve at all levels. Thank you.
Well, thank you, Carolyn. It does take courage to ask for help, and particularly from someone who may not have had the same, in most cases, will not have had the same experiences as you. I know compared to what Vietnam veterans went through, this is certainly a very warm and welcoming environment in this country for these folks. But still, the civilian population that's never experienced service and therefore never experienced combat is still largely ignorant of military culture. And that's why we offer presentations like this to you. We don't expect you to be experts after having sat here with us for the last 60 to 90 minutes, but we expect that you will be better acquainted, not necessarily in the area of mil-speak, as Carolyn referred to it, but in the area of not being able to misspeak mil-speak. Even I once, and this was only a couple of months ago, I introduced somebody as a former Marine at a meeting, and I got an earful after that meeting because there's no such thing as a former Marine, and I probably should have known that, but I didn't. So even little things like it's not a rifle or a gun, it's a weapon, you know. Boot camp, we talked about that early on in one of the first slides. I believe boot camp is something related to the Marines only.
I called it boot camp in the Air Force.
Okay, I
Am I
didn't know
allowed?
that. See, I didn't know that. But, you know, it's a camp in the Marines, it's a base in the Air Force, and it's a post in the Army. Little things like that. We don't expect you to know that, but understand that these folks are most comfortable with their own kind. I've often heard the term battle buddies. And they will be most comfortable with you when they show up asking for help if you treat them with respect and understanding. And that's why we brought this session to you, and I hope you've enjoyed it and gotten a lot out of it. And I wanted to thank Dr. Carolyn Jackson very much for again stepping up to the plate. This is like the third time I've asked her to do this. And she's been to Watertown, Queens, and now Albany. And we'll try and find other locations for her to travel to. So thank you, Carolyn.
Thank you. It's been my pleasure. Thank you for having me.
As Paul and Carolyn said when they finished their presentation, it takes the courage and strength of a warrior to ask for help. And that was part of the reason for this presentation today, for you to begin to be ready when they come to your treatment, prevention, and recovery doors to ask for help. That being said, I do want to thank Dr. Jackson and Paul for their conversation that took place today. It took place today, and hopefully it's the beginning of a conversation that will continue to take place. Okay, and finally, as always, your feedback is appreciated. It's one way for OASAS to determine and assess if we are meeting the educational wants and needs of the field. At the end of this presentation, you will find a SurveyMonkey link. If you would take a moment to complete the survey, we would appreciate it. As a reminder, folks, please feel free to send questions to learningthurs@oasas.ny.gov. This is Patty again. Thank you for joining us, and enjoy your day. Bye now.